Welcome to the Vital Health Podcast. I'm Duane Schulthess, the CEO of Vital Transformation. Over the past year, the Inflation Reduction Act has moved from policy to active implementation. As the rollout has progressed, companies across the system have adjusted how they plan, assess risk, and make decisions, from early-stage investment in drug development to coverage and access. In this Policy Highlights edition of the Vital Health Podcast, we look back on the most important conversations we had in 2025 about the IRA and questions that matter going forward. You'll hear a wide range of perspectives from experts in healthcare and life sciences. I'll briefly introduce you to each guest as we go, and then we'll go straight into the clips. Opinions expressed are those of the speakers. Up next, we spoke with Donna Cryer, founder of the Global Liver Institute. We're seeing enormous impacts because companies are starting to avoid drugs for the Medicare age population. Now, that deals with all indications. What about from the rare orphan space? Mm-hmm. You are here. I'm talking to you because you have an effective treatment.
Right.
A lot of people with orphan conditions aren't in that luxuriant position. What are you concerned about the IRA related to orphan and rare conditions?
My constituents, if you will, of patients. For the Global Liver Institute, we have liver cancer patients. We have patients with common diseases, unfortunately, fatty liver disease or metabolic associated steatohepatitis is an all too common disease. And then we have a collection of over 100 different rare liver diseases. And that doesn't even, start to talk about the liver cancers that metastasize and are rare cancers, so we cross over those as well. And I would add a layer to that too, because complexity is always helpful.
Yeah, of course. And this town loves complexity. We love complex solutions to complex problems here.
So let me just add on that. I truly believe that having a successful health outcome for an individual will usually take excellence in diagnostics, surgical options. I, as an individual patient, am on biological medications. I have, infusions, injections, and small, pills. And so it's not as simple as saying, to protect cancer or rare, we need one type or one formulation for one age group. It's going to need more than that. And I think the importance is to keep the flexibility and the nimbleness and the ability of our drug manufacturers and device manufacturers to be able to pivot and to be able to respond to patient needs and to their research opportunities. And any policy framework that doesn't allow that full range of innovation will, by definition, negatively impact care. So yes, our patients are often covered under Medicare or of a Medicare age, but we have patients who are in Medicaid because they're pregnant women with liver disease or infants and children, working age populations who might be covered under the Affordable Care Act plans or have private payers, and so look to Medicare, as a symbol. What happens under the IRA and under, I'm using air quotes, under negotiations, will affect everyone.
It's a real problem, too. I'm seeing a bifurcation in the advocacy in the orphan community. There was just a study published a couple weeks ago by an advocacy organization in town, and basically the whole tenor of the report was, hey, 95% of all orphan drugs, it's not going to be impacted by IRA. Who cares? We don't really need to worry about it. And I just about, fell out of my chair because it's like, yeah, but what about late-stage cancers? What about non-responsive liver cancers that have a rare subtype that you don't currently have an effective treatment? 80% of accelerated approvals were oncology products targeting late-stage cancers. Now, why is this important? Because rituximab is a hugely effective therapy, and I'm just going to, this has nothing to do with liver care per se, but if we look at leukemia, for example, DLBCL lymphoma, rituximab cures 2/3, 70%. But what are we just saying? The rest of the 30%, sorry, tough luck. That's on you. Sorry, we don't care anymore. It seems rather foolhardily closed-minded.
It's very easy to focus on, what condition you have. And I always add, at this time.
Right.
because you never know what you might be diagnosed with tomorrow, and then that's still very, very self-centered. I just think that helping the advocacy community succeed as a whole through partnership and collaboration and increased understanding sometimes means standing down from your own issue. It also means, in this case, just sort of broadening your time horizon. If you are the type of condition that, you're the first indication, all may be well with you. But for many rare conditions, you're the second and third. And if the incentives aren't so that people get to their second and third indication, which requires investments of millions of dollars of research, you may just not get that drug. You may never get it. Access is meaningless if it wasn't invented in the first place.
Yeah.
And I see the incentives. Put yourselves in the mindset of a manufacturer, board or CEO, and they're looking, at this and making their decisions about where will their investment pay off. And so they're, rational responses, even if they're not the responses we would like them to be as patients or representatives of certain groups, we have to recognize them as rational responses and change those incentives. And in this case, change the policy. I also think that, as I was listening to you, one of the roles that I had in the past too was helping to manage and giving best practices for managing oncology back offices.
Yeah.
And there are very different models for, how your physicians may administer or get drugs. But usually in oncology, particularly community oncology practices, the physician will pay up front for a certain amount of drug.
Yeah.
The prices that are often quoted in the news are not real.
Yeah.
is what I want to say.
From an economic standpoint, we say they're lacking transparency.
They're lacking transparency or foundation.
Yeah.
And so, whenever I, see an average wholesale price or, or WACR, there are different acronyms and things. I'm like, well, nobody actually pays that.
Yeah.
And we haven't even gotten into the, the PBMs and the rebates and the other distortions of the system. And so I like to try to stay, reality-based in my advocacy. And so I can't be overreacting to prices that I know nobody really is paying, and certainly feeling great about being told that there are savings from a price that was never true to begin with. And so I just think that there does need to be more transparency. There does need to be more reality. And there does need to be, a little more education so that people actually understand what is happening and the consequences of that. I think that would benefit the people drafting, the people executing, as well as the people sort of receiving or participating as well.
The number of people, very, very smart people in this town. Do you see any regulatory relief like the EPIC Act that they're talking about for the 913 aspects of IRA? Would that help, or is it beyond that? Is there anything that you see in the near term that could fix this or help?
I think the EPIC Act is absolutely something I support. I always think it's a good idea when you have physicians and other nurses, healthcare providers as members of Congress to understand these issues. I'm excited to walk into an office, of a physician-led or a nurse-led office of Congress to explain healthcare issues in context. They get it. They get this importance. And so I think the EPIC Act is really important to, as we were talking about, to make sure that those incentives are evened out so that pills have as good of a chance as, this same type of time frame to be able to recoup the investment to develop them as a biologic. We need both. Throughout the digestive space in particular, patients may go through at various times having the opportunity to choose a biologic or a pill or a subcutaneous injection. And that's just not, somebody fooling around with patents or something. Those are creating really different types of treatment with effectiveness in different populations, giving people real choices, giving them also freedom of their lives, the ability to take a small pill and then, travel is very different than having to, report to an infusion center every few weeks. And so that is an important part of what innovation means, what a mature therapy means and of giving people real choice and real access. If you live in a rural area, hundreds of miles from a major treatment center is, a major academic center is, having a pill available for your condition may mean the difference between you being treated for your condition and not.
Or being able to afford it.
And being able to afford it, absolutely.
Up next, we spoke with Barbara McEnany, past president of the American Medical Association and CEO of New Mexico Oncology Hematology Consultants, Rafael Fonseca, Chief Innovation Officer at the Mayo Clinic in Arizona, and Steve Potts, Chair of the Drug Development Council at the International Cancer Advocacy Network, ICANN. We recently published at Vital Transformation a study called the Inflation Reduction Act's Impact on Early-Stage Venture Capital Investments. We found enormous negative impacts for the Medicare-age population due to the IRA, particularly in small molecules. Barbara, I'm going to start with you. You're a clinical trialist. We're seeing venture capitalists and angels in some of these early-stage clinical trials pull back in the data. Are you seeing this on the ground in your practice?
We are finding that the trials we are offered are less small molecules and more things like radiopharmaceuticals or theranostics or immunotherapy attached to various compounds. We are not seeing as much of third, fourth, fifth indication for a drug.
You run a series of cancer centers. Is this impacting your ability to deliver care?
Well, I'm co-chair of OnCare Alliance, which is a group of 32 independent oncology practices coast to coast, and we all do clinical trials ranging from phase 1 to phase 3. And what we're seeing is that there are fewer opportunities to take an orphan drug and add a new indication, which means when we know that it's working for that, we can use it off-label, but insurance companies try to deny it when it's off-label. We have to get the information we can gather for them. It's much easier to get these drugs to patients if there is a randomized controlled trial we can quote instead of just case reports.
Rafael, picking up on what Barbara just said, you're an independent oncologist, but you're not working in a small institution. Generally, you've been working at places like the Mayo Clinic. How is this impacting what you're seeing on the ground?
The net effects of what will occur with full implementation of IRA will take some years before they realize. And the effects that I see that are immediate are the same as were just described with regards to the clinical trials. Our interactions with the larger companies, they already have had a pipeline, and they're starting to rethink what may be secondary clinical trials that may lead to expanded uses of the drugs. And as Dr. McEnany was saying, if you don't have those indications, it becomes problematic. So then we have to be doing the peer-to-peer and those things. The net impact that I see that is greater right now is in our conversations with early developers and biotech, because everyone is saying, hey, is there something we can do to make this a biologic, or can we do this in such a way that it's not going to fall under the small molecule restrictions that we have? So artificially it changes the conversation, and it involves a new level of practicality that may, in a not good way, sometimes deviate from the scientific directory, which is just get the best product available for patients.
Just to be clear, you're saying that people are coming to you and specifically trying to swap out a modality from small to large.
Yes.
Is this happening fairly late in the game? Are we talking phase 3, phase 2, or is this safety?
No, this is pretty early. The people that already have the pipeline and have had the phase 1 and phase 2, for them it's more the hesitation. Does it make sense to keep pursuing something if I'm not going to have that time, right? If you have a molecule. But the main conversations are at the very early stage in both preclinical and phase 1, where biotech is rethinking what they should do, because they have to look at the whole calculation, and they have their investors, and they have to look at the net present value. And with all of that in mind, sometimes it doesn't make sense for them to move forward.
So, Steve, obviously this is your wheelhouse now. You are a biotech entrepreneur. You've done this for real and very successfully many times. How are you dealing with this modality issue? Are you changing the way you're looking at small and large molecules when you're approaching clinical research now?
The early stage was kind of the canary in the coal mine on IRA. We saw it immediately 3 years ago. I mean, I couldn't get a company funded small molecule-wise that would have gotten funded prior to the IRA. And this stuff is hard. I mean, I've been doing this 25 years. I've been involved in 2 drugs that were approved and a whole ton of things that don't work out. That is drug development. And so we do not need the headwind that we have. The bicycling was hard enough before that. the tragedy here from a patient standpoint is that you just don't know in oncology where the best drug is going to help the most patients. Right when we're at the peak of like our coolest stuff with precision medicine of trying to get fingerprints of what kinds of cancers might be helped by what kinds of mechanisms, and we come out with these molecules, all of a sudden we get this just massive headwind. It's not interesting economically. I mean, you just can't get it funded. So you just see whole patient populations that are not going to get the opportunity to see if the drug is going to work there. And take multiple myeloma first. And you think of all the progress there and then say, okay, if the IRA small molecule penalty had been in place when you started your career, Dr. Fonseca, how interesting would have been the myeloma space with its 25,000 patients per year? What would have happened? And they're mostly elderly too. So what would that have looked like?
That's a very quick and simple answer. We wouldn't be where we are. And there has been so much progress that has occurred over the last 25 years. Some background, when I first started, the median survival for patients barely exceeded 2 years. Nowadays, it exceeds 15 years for most patients. And in fact, I believe there's a significant fraction of patients, still a minority, but a significant fraction, that are being cured from their disease. Now, how did this all get started? With small molecules. Small molecules like thalidomide and its derivatives, lenalidomide and pomalidomide, led to a boom in the development of compounds for the treatment of myeloma. And this was almost in parallel with the development of proteasome inhibitors, which are also small molecules. Now, because of these two developments, we could add them to steroids, which of course we've had for many years. But this just generated such interest in myeloma that the consequence that a lot of people paid attention to that. And we know that drug development is a multifaceted, multidisciplinary, complex process, right? So as you have people that are seeing that there's a path for success in myeloma, that got a lot of attention. And that led to the subsequent development of things like monoclonal antibodies. And nowadays, we're even using CAR-Ts and bispecifics. But it is without a doubt that we wouldn't have those treatments if we didn't have those first steps that were truly revolutionary in our ability to treat the disease with those small molecules. So it all is a concatenation. It all builds on previous success. But that's what it took to get us to where we are today.
That's a really good point, Rafael. And Barbara, coming back to you, this issue of the orphanization problem, where now we're moving away from that. If you think about lymphoma and the success of rituximab, which is now essentially borderline free, it's generic, the reality is you're not going to want to compete with rituximab. You're going to want to look at that population that isn't responding. What's going to happen if we can't deal with that clinically? What happens to your patients? What are you going to do?
It puts physicians in practice in really an untenable position that we should never be put in. And I think this will start in 2026 when we start to see the oral impact of the first 10 drugs. And then by 2028, when it kicks in the Part B infusible drugs, I think that will have a huge and negative impact. So let me explain what I mean by that. As certain orals become impossible to purchase and to provide through our in-house pharmacies, and most oncology practices prefer to have in-house pharmacies because often these drugs are used in combination with other therapies, and when you have to send them off to the pharmacy benefit managers and you don't know when they're going to actually get their orals, trying to treat patients is very difficult. And we pay 2 people in my own office just to call people up and say, has the PBM sent your drug yet? And then 2 days later, they call them again. Do you have your drug yet? And the answer is often no, and it takes a couple weeks, which is not good care. The second thing we find is that if we are allowed to prescribe and bill and collect for certain of the drugs on the list, we may find that we are subsidizing Medicare as an independent practice. If I have to buy the apple at $5 and sell it for $4, I'm not going to be able to continue to buy those apples. So the same thing may be true for some of our very effective drugs for the orals. When it gets to the intravenous drugs in 2028, that will put oncologists in the position of trying to decide between the patient in front of me who needs this drug that I know if I purchase it at average sales price and I'm reimbursed at maximum fair price, then I will be out of business in about 6 months. So either I have to deny the patient in front of me the drug that's the best drug for them, Or 6 months later, I'm denying a lot of patients access to the clinic because if I can't make payroll, we're not going to be there anymore. So this is very, very serious to us. The OnCare Alliance group of practices, we are often in urban areas, but we often have the satellites or the small clinics in rural America, places where there is no way to get to an academic medical center or do any other tertiary center to get to those drugs. So if I'm in an urban area and I say, I can't afford to give you this drug, I can tell the patient, go try to get it at the local hospital, often the 340B hospital. If I can't, or they can't get in, which is the usual event, then we're stuck. That patient doesn't get the drug they need, or I give the patient that drug and put my practice out of business. That's a Sophie's choice that physicians should never have to make.
Raphael, are you seeing similar concerns being expressed?
Yes, we are. I'm going to second a very important point that Barbara made and then see why we don't see as much pushback yet from particularly academic centers. And that is individuals like Barbara that have to run their practice are attuned to the realities of the world and the economics of what it takes to provide cancer care. I would say that when you look at the medical literature, and there's individuals who, I'm going to say probably all very well-intentioned, wanting to change the format, sometimes thinking, oh, this is going to be a great step, don't realize how detrimental this will be to the provision of care for patients. Because if you don't have the direct expertise on what it takes to provide cancer care and what the economics are behind that, you won't realize how damaging some of this could be. Also, 2026 might be a significant time when we see those changes. And I do worry that beyond that, we'll see even more change because of the detriment of the enthusiasm behind the development of all those small molecules.
So, Steve, when you're choosing your clinical trial portfolio and where you want to go and who you want to work with, how are you changing your decisions now based on what's going on with IRA? How are you managing your clinical research?
The government is deciding which patients we want to go after.
Wow.
And also which modalities to use.
Just because of the disincentives?
Let that sink in a little bit.
Wow.
And then think about how much, just as one example, we always are fighting brain metastases, not to mention primary brain tumors, but brain metastases is a huge part of what you don't want to have with a cancer patient. And what modality do you think is best for a crossing a blood-brain barrier? It's a small molecule.
Of course.
And even if you get a great biologic, and that biologic could be a bispecific, it could be a antibody drug conjugate, it typically doesn't access the brain very well. So what do? You get a little nice park for the cancer to go grow, and then you don't have a small molecule to go after that. Bottom line, we're making decisions based on the government. Right when we have just so much interesting promise, and it's small molecule, and then it's the elderly, it's a double hit. The heme oncology area is so much elderly driven, and all the amazing progress has been done in that area that Raphael touched from. That's very much, these are diseases of the elderly, which is exactly what's being hit.
Steve, what would you do if you've got something you could implement in 6 months?
We have learned absolutely that we cannot fund with 9 years of return. It does not work. I wish it was 15, but 13, I think if we could move the 9 years to 13 and fix the small molecule penalty, it would help. The other magic wand is not actually a change. It's a change to awareness. I wish that in every American family room, they would realize that the IRA did fix something that needed to be fixed, which is that there were drugs, biologics, that were not going generic in time. I wish it was 15, but 13 years has fixed that. There's only so much money that's going to go to drugs, 8-9%, it's pretty static. And when that goes to a drug that has had way too long of a patent, various things, that's money that's not going to the brand new cancer drugs.
Up next, we spoke with Kirsten Axelson, a fellow at the Aspen Institute and a visiting scholar at the American Enterprise Institute. What was IRA, at least rhetorically, when the bill was being walked through Congress and Senate in 2022, when Joe Manchin and Biden and Schumer had cut the deal, basically to take Build Back Better and make it Inflation Reduction Act? What was it supposed to do? What was it supposed to accomplish?
Save money for the federal government and correct some distortion. The amount the federal government was spending in subsidizing the catastrophic coverage in Medicare had been growing and growing rapidly, and essentially was making plans cost insensitive to higher cost drugs. That was accomplished, I would argue, maybe moved in a bit too quickly. I think it was intended to scratch a popular itch that the government would control the prices of drugs just the way they do in other countries. In reality, we saw with the first 10 medicines that were selected, there wasn't much savings. It was largely offset by the billions that were spent to subsidize the premiums that went up. And I think we're going to see, as the additional drugs have their price controls, either limited cost savings because there's already an out-of-pocket cap, or other distorting effects of how drugs are covered. It accomplished a number of things in terms of patient out-of-pocket costs. I do think the $2,000 out-of-pocket cap, or some sort of an out-of-pocket cap, was an appropriate and necessary measure, and price controls on the drugs were maybe part of what, and the reduction in the catastrophic subsidy were part of what helped fund the out-of-pocket maximum. I mean, you could say you may have been able to accomplish this without the price controls if you had, for example, a income gradated out-of-pocket cap, or there were probably other ways of getting to this that might have not had such a distorting effect, in particular on small molecules in the program.
Yeah, and one of the challenges with the Inflation Reduction Act that you've alluded to, and we did a study on it called the Inflation Reduction Act's Impact on Early Stage Venture Capital Investments. If you look at the early side where investors are coming in now, because you have this disparity, this 9 years for small molecules before they're negotiated, and this 13 years for large molecules before they're negotiated, this creates enormous profit disincentives for venture capitalists from a risk standpoint, because the majority of these, even if they're great assets and great teams, 90% of them fail. And so you're already taking a 1 in 10 shot on goal to succeed, and then you're saying, oh, and we're going to reduce your potential profit by 50%. Now, we're not seeing an exodus in the phase 3 stuff. So companies that have gone all in, they've actually taken things to phase 3. They're continuing to bring them to market. But what we're seeing is in the early stage where people can pivot and move away, we are detecting that shift. Why do you think this was not picked up by a lot of the analysis? Because CBO, when they gave their assessment, said, oh, we're only going to lose 2 drugs every 10 years. You had all of the CEOs parading, 2 months after the bill was passed, going to JP Morgan that January. Oh, no, we don't think there's going to be a problem. And there was like a common sense issue in DC where it's like, oh, heck, this isn't going to be that bad. But now we're seeing it is bad. Why did people get it so wrong?
When you think about what the CBO was asked to do, which is essentially could be a lifetime's work of economic research and has been for many people, right? Like, look at all the greats that have studied this for years, decades, and attempted to quantify the impact of market size on investment and innovation. And we have a range of estimates, and we don't know with 100% certainty that none of them are right. The approach to take to this is more like the one you did, which is, of course, was post hoc. You couldn't use it forecasting, but to really think deeply about, venture investment. I don't think anyone, no matter how smart, no matter how capable, could have developed a model that forecast such a seismic change in the world's biggest market. And the CBO was tasked with doing that. Again, I think with very little industry input. I don't know how many people on your team worked on your model, but I suspect you had more manpower on yours than the one that was asked to forecast this huge implications for the world's leading market for drugs. So the model definitely has some limitations. My main beef with the model and how it's communicated is just the way it's been communicated as though that's the fact. It's 8 drugs, it's 30 drugs, that's it. And again, I think that's how the CBO is asked to communicate to Congress. There's no ranges, there's no bands of uncertainty. But no, that wouldn't get published in any academic journal, right? So to me, it's more how Congress uses this information and directing the CBO to communicate the information. It's probably somewhere between 300 drugs and 3 drugs. I mean, look, it's possible that the industry just switches to doing different types of drug development and we lose small molecule innovation, for example. Like, we don't really know. So I think that's why it was gotten wrong so early on. In a post hoc world, I mean, some people looked at earnings statements for the big companies right after the IRA. Well, like you said, anything phase 3, probably even phase 2 is going to be continued. What we're going to see is the post-market research not get done.
Yeah.
And then I think the venture investment, I mean, as you saw, and I've read your study, is very hard, takes a lot of manpower and a lot of time.
You're right. I think that's hard to do. And I think with the CBO, the big challenge they had was a time one. They had to get this done, so they did everything based on elasticities and of market demand, which is an aggregate model. But unfortunately, people like Peter Kolchinsky and Steve Potts and John LaMattina, they're not investing in the aggregate. They're investing in a specific asset that has a specific mechanism of action and addresses a specific population. And that's hard to do. That's hard to do. Unfortunately, a lot of people as well are economists at the large scale, and they don't actually not invested in drugs. What do you think is going to happen now, because we are seeing this NME problem, this new molecular entity issue versus the biologics? We are seeing companies getting shy early stage to bring an NME to Medicare if it's going to have a lot of Medicare exposure. There's another challenge here because biologics, they don't have rebates and they're more expensive. Basically, Medicare is going to get hit twice. They're going to have higher cost of drugs, higher cost of delivery, and they're not going to have the rebates to subsidize premiums. What's going to happen here? Where does the rubber hit the road?
I think we will see an impact on small molecule development, both in terms of less willingness to bring a therapy to the market. Now, I think the argument I've heard is, oh, well, it's just the marginal drugs. Again, I would encourage people who believe that to, as much as they feel they can trust them, talk to people who are in the business of drug development. You don't know a marginal drug in phase 1. You might not know a marginal drug in phase 2.
And often phase 3.
Often phase 3. And sometimes you don't know a marginal drug till it's on the market and it fails, which, again, I would argue getting a drug on the market that fails to be successful commercially because it wasn't good enough for patient health is better than having it never get through clinical development, because you learn something from that, the world learns something from that, and some of that competition might just bring down some prices in a multi-therapeutic area. So I do think it is a pretty serious thing that some NMEs might not make it through the drug development pathway. If there is a shift to biologics, it's a real problem, right? Like, we don't have a lot of uptake of biosimilars in this country. They're often not on the formulary. This is not a patent issue. There are multiple products where there are multiple biosimilars approved, and they're not being placed on the formulary. They're not being used because sort of the financial incentives aren't there. So it's going to really increase costs. The other concern I have with the Medicare price controls is if you push down the market size, you're not going to have generic competition either.
Yeah.
So these big drugs, Eliquis, Xarelto, some of these huge blockbusters who already had deep discounts, typically when those drugs went off patent, you would have the deep discounts go away. They're now very high. There's a big delta between that and the generic, and we switch over to generics. Well, now the government's pushed down the price, so there's less of an incentive to even enter the market as a generic, especially because there's price inflation penalties on them too. If we don't have a robust generics market, we have a real cost problem here. I mean, we're sitting in a world where at some point we're going to have generic Hep C medicines.
Yeah.
That's an incredible world. We don't have generic heart surgeons. We need generic drugs to keep down costs, and we need uptake of biosimilars to take down costs. And this law is the opposite of creating incentives for that kind of competition.
And the problem is when you do the math on this and you look at the benefit redesign and then you start looking at the biologic world and the biosimilar world, you start realizing there's very little incentive for an insurer to swap to even a biosimilar where they're getting it at the marginal cost. What you're going to see under the new design, the only way that they do not lose money is if they actually produce it and own it themselves and rebate back to themselves. That's the only way in that value chain. When you actually run all the numbers and do all the math, you realize, oh, hey, wait a minute. They're still losing money at this rock bottom price now. And in fact, the only way that stops is if they were to cut a deal and start making their own products. And what are you seeing? Blue Cross Blue Shield now has a partnership to develop their own Humira. UHC is developing their own biologics and biosimilars. There's a reason why. It's because that's where the incentives are running. So not only are you going to get fewer generics, the ones you're going to get, or the biosimilars, are going to be owned in channel. And it's like you're going to be buying not Tide anymore. You're going to get Walmart's version of Tide, and it's your new biologic. Again, just complete missing of the incentives, the way the market works. How does that get fixed? Can it get fixed?
I've always thought the copay on biosimilars should be low, like the copay on generics is, right? You could do a number of that, create more incentives for the use of biosimilars. That doesn't solve your vertical integration problem that you just mentioned, but at least for the uptake of biosimilars. I mean, get rid of the price controls in Medicare would be one way to fix it. Create rewards or incentives for launching a biosimilar that maybe could be transferred to a biologic. I don't know. There's all kinds of tricks in the basket, but how many times do we need to observe government price controls creating market monopolies for a few companies to understand that's what government price controls do?
Yeah.
And so this is completely predictable.
I went to your panel at ASCO in Chicago. You mentioned earlier the issue of follow-on research. What are you finding on follow-on research and some of the knock-on impacts of IRA, some of these tertiary and quartile impacts that people have missed? What are we looking at right now?
So we've evaluated this for oncology medicines, for example. The work I've done so far has been sort of in a forecasting way. If you were to look historically at oncology medicines, a huge percentage of them have post-market research for additional indications for children and combination therapy. So, with forecast models, we're anticipating that a lot of that would go away. People say, oh, it won't go away entirely. There's still post-market studies for generic drugs. That's true. But that tends to be in either NIH-funded research or companies that are big and continue to give back by continuing to do studies, for example, on like an antibiotic in sub-Saharan Africa, that kind of thing. So, yes, you still do see post-market research without a profit incentive, but you see a lot more post-market research with a profit incentive when you can expand the population. So I think we're going to see less of that. I think we're going to see more niche product innovation, which is fine if that's the right thing for science. If it's being done to avoid getting enough revenue to hit the IRA, those are going to be some expensive, tiny drugs. And with what we know about the human genome, you could essentially create thousands of small market drugs and avoid this government incentive. Again, fine if it improves health. Not fine if it's just a costly way to avoid this distortionary policy.
Now, one of the things that's been rolled out to sort of fix some of these disincentives was the EPIC Act. The idea that it would move the 9 and 13 pill penalty is quoted by Peter Kolchinsky. What's interesting is the bill doesn't actually say it has to move to 13-13. It could be 11-11, could be 9-9. And with this administration, I mean, game on. Who knows where it ends up? Theoretically, I think we're all assuming it's going to be 13-13. Now, it was not included in reconciliation. What do you think are the possibilities of this actually getting picked up by Congress in the next, before the midterms in 18 months?
Whether it comes back and gets passed into law is hard because it will cost money. And we have a lot of other big costly things to manage right now, right? Like the ACA subsidies, for example. We're going to start to see the impact of the Medicaid cuts and, you can keep going on. So I think it is an uphill battle in the near term. And when I testified before the Senate Finance Committee last spring, I suggested something, EPIC Act-like. You could even do 13 for everybody in Medicare, right? You could get to a place where it's not particularly distortionary. You typically see drugs go off patent after 13 to 14 years.
Yeah.
You'd create some incentive structure for a generic or a biosimilar to enter that, 13 years, either you've got an active generic or biosimilar in the market, or your price goes down to 20% of FSS, whatever it is, something predictable. You don't need then billions of dollars and a ton of infrastructure to do this charade of price setting. And the reason I say I think it's a charade is because there's a price ceiling. And when there's a price ceiling, by definition, you can't have a value-based price, right? You can't tell me I'll pay whatever you want for your car, not more than $500, and it'll be a great deal for you. Think of what the drug companies must be investing into this negotiation process.
Time, effort, and energy alone.
Yes. Right. And CMS personnel, and I guess no one's crying for the drug companies having to waste money on this, but it could go back to shareholders, it could go back into R&D, it could go towards a number of places, and then you would also help investors if you just said, this is the plan. In Medicare, you get 13 years. That's it. So I do think there are other ways to scratch this itch that would be less distorting to small molecules.
Our editor is Mark Brodeen. Our project manager is Caden Drake. The Vital Health Podcast is a production of Vital Transformation, LLC, copyright 2025.